Now, please allow me to introduce our second speaker, our young assistant professor, Dr. Sharanya Nama. She is an interventional pain management physician at the Ohio State University Medical Center in Columbus, USA. She grew up outside of Pittsburgh, Pennsylvania, attended Temple University School of Medicine, and then completed her residency and fellowship training at the University of Pittsburgh Medical Center. She has been practicing pain medicine for 6 years, and her interests includes pain management in patients with substance use disorder and perioperative pain management for patients with opioid tolerance. She lives in Dublin and USA. She's presenting to us her lecture on perioperative buprenorphine management. Please, Dr. Nama, share, the floor is yours, and please share your screen.
Thank you so much for having me speak at this webinar. And yes, I'm going to be talking about perioperative buprenorphine management today. I want to take this opportunity to thank Dr. Mahdi, Dr. Sohair, and Dr. Barbara Rogers, who's my mentor, for making the introduction. I have no disclosures. Can everyone hear me? I'm switched to my AirPods.
Yeah, we do. Thank you.
Okay, perfect. All right. So the objectives of today's talk is, one, I would like to increase understanding in the pharmacologic differences between buprenorphine and other opioids. Secondly, I would like to highlight the consequences of stopping buprenorphine in the perioperative period. And third, I would like to discuss and review strategies to optimize pain control in this patient population. I'm going to start with a hypothetical clinical scenario first to kind of give an example of what could happen. This is a 42-year-old patient with past medical history of end-stage liver disease from hepatitis C. He was admitted postoperatively after undergoing a liver transplantation. This patient has a history of opioid use disorder, had been abstinent from opioids and drug use for about 4 years, and was successfully treated with buprenorphine and naloxone combination called Suboxone. It's trade name here. The patient received his last dose of Suboxone about 36 hours prior to surgery, as instructed by his clinicians. They gave him a call. They said, we have a liver waiting for you. Stop taking your Suboxone. And so the patient was not restarted on Suboxone postoperatively. And this patient agreed to the plan of restarting his Suboxone prior to discharge from the hospital. Unfortunately, things did go downhill. His clinical course, postoperative course, did not go well. Initially, the patient refused to be weaned off of his patient-controlled analgesia with hydromorphone. He also refused to restart the buprenorphine as previously agreed upon, and threatened to leave the hospital against the medical advice. They found drug paraphernalia in his room on postoperative day 8, and this patient continues to do poorly after discharge. Examples being that he works for a drug dealer now as a drug mule, or he was incarcerated, and of course the liver is in acute rejection. So wanted to give some background of the opioid epidemic in the USA. I know there's so many people from so many countries, so I couldn't look up other statistics from elsewhere, but I will present what I know about my own country. So unfortunately, in 2020, Approximately 90,000 Americans died from opioid overdose, and this was a sharp rise from the 70,000 deaths that happened in 2019. This was from illicit drugs and also prescription opioids. And they think that the COVID pandemic has largely contributed to this very dramatic rise. In fact, 2017 seemed to be a turning point for us, where deaths from heroin and prescribed opioids actually started coming down, as you can see in this chart here. But unfortunately, the introduction of synthetic opioids like fentanyl has made deaths worse, and also the COVID pandemic. And so how do we treat patients with opioid use disorder? The treatment options are detoxification versus using a medication to help with treating opioid disorder. Detoxification is simply abstinence from the offending medication or drug, and then symptom management for the withdrawal. And then this is usually done in conjunction with cognitive behavioral approaches and therapy. And then the other option, along with therapy, is it's called medication treatment of opioid use disorder or medication assisted therapy. So MOUD or MAT. And so they're transitioning in the US from calling it MAT to calling it MOUD. And so this is when we use a medication to reduce cravings and withdrawal symptoms. And so the three most commonly used medications are buprenorphine, methadone, and naltrexone. And so I'd like to focus today's talk on buprenorphine. It is a unique opioid. So in the US, it is FDA approved for opioid use disorder, the treatment of opioid use disorder, acute pain, and also chronic pain. There are several formulations for opioid use disorder. There's buprenorphine alone, which is called Subutex, and Suboxone, which is a buprenorphine naloxone combination. Both of these are sublingual. It is thought that the naloxone helps the buprenorphine be more abuse deterrent, because if this were to be injected intravenously, the naloxone would be able to counteract any effects of the buprenorphine. Sublocade is a extended release subcutaneous injection, and this is actually what's becoming more and more popular. Once the patient is on a stable dose of Suboxone, they can be transitioned to Sublocade, and they get an injection once a month. There are a couple of other formulations, Probufene and Bonafale. The Probufene is a subdermal implant, and Bonafale is a buccal film. These two are less common, and they are more expensive. For acute pain, there's an IV formulation of buprenorphine that we call Buprenex that is available, and only certain services in the hospital can use this. And then for chronic pain, there is these two forms of buprenorphine that are in much smaller dosing, in microdosing quantities. So Belbuca is a buccal film, and the Butrans patch is a transdermal patch. So this medication is mechanistically different from other opioids. It's considered a partial mu receptor agonist. So when it does bind the mu receptor, it has a lower intrinsic activity, but it also has a very high receptor affinity and slow dissociation rate from the receptor. It is also a full kappa receptor antagonist, full blocker of the kappa receptor. Its half-life is about 26 hours, so relatively long, but it does have analgesic properties. Those last from 6 to 8 hours. It is not the full 26 hours. is thought to be anti-hyperalgesic and have a ceiling effect on respiratory depression. And so this figure shows the proposed mechanism of how buprenorphine is analgesic and anti-hyperalgesic. Through the mu opioid receptor, it has its analgesic effects, but it's thought that through the kappa opioid receptor and blocking that, it ultimately can block NMDA receptor firing. And so the NMDA receptor is what is thought to be the reason. The activation of the NMDA receptor is what's thought to cause central sensitization and hyperalgesia. I wanted to show this diagram of all the 3 different treatments for opioid use disorder and their effect on the opioid receptor. So methadone is considered a full opioid agonist, and so we'll have a full opioid effect. Buprenorphine is this orange line right here, and that has a partial agonist effect, and naloxone and naltrexone as well are blockers and antagonists, so they have no effect at the opioid receptor. And so this is a diagram from a study done by Dahan et al. And it shows the effect of minute ventilation with increasing doses of buprenorphine versus fentanyl. So in the lab animals. So on the left, you can see the effect of increasing doses of fentanyl for the minute ventilation of this animal. It precipitously decreases down to 0. However, for buprenorphine, the minute ventilation does decrease. However, it stops decreasing, it plateaus at a certain level, making it theoretically safer, even if a patient overdoses, takes too much of their buprenorphine, their ventilation doesn't go to 0, theoretically. And so how does buprenorphine prevent relapse in patients with opioid use disorder? It has this exceptionally high affinity to the mu receptor, like I mentioned before. So this actually prevents other opioids from binding to the mu receptor, and also leads to the lack of euphoria that happens when patients if patients were to use. And ultimately, this decreases cravings for using fentanyl or heroin, etc. The goal of when you're treating somebody with opioid use disorder with buprenorphine is to saturate as many mu receptors as possible. But unfortunately, it's these unavailable mu receptors that are now blocked by buprenorphine that makes pain control with opioids in these patients very, very difficult. And so this is a chart from Greenwald et al. That shows receptor occupancy at different doses of buprenorphine. So a patient who's taking 2 milligrams daily, it's thought that they have about 41% of their mu receptors blocked. And so 16 milligrams seems to be like that magic number that clinicians try to put patients on. It is thought that it blocks about 85 to 92% of the mu receptors in the CNS, and then 32 milligrams really virtually binds all of the mu receptors. So this diagram is from Zubieta et al., and they published back in 2000 a study where they took healthy volunteers and they gave them different doses of buprenorphine. So we have the control group, one that was given no buprenorphine, one that was given 2 milligrams, and one that was given 16 milligrams. And they were then administered radio-labeled carfentanil to see how much of this carfentanil would then bind and took fMRI images. And so you can see the control and the 0 milligram buprenorphine patients, they had pretty robust binding of the radio labeled carfentanil. However, the 2 milligram group, they had less binding, and the 16 milligram group had even less binding. So I wanted to discuss what exactly is buprenorphine induction, and what is the steps in the process. Okay, so an induction just means slow initiation and titration of buprenorphine. It can be done in various settings, office-based setting, in the hospital, inpatient, or even in the emergency room. And even there's home protocols for patients to go home and start buprenorphine. And so the patient must be in clinical withdrawal prior to doing a buprenorphine induction. And so this would be based on the clinical opioid withdrawal scale, and they would need to have a COWS score of greater than 12. And so the reason for this is that it helps prevent a phenomenon called precipitated withdrawal. As we all know that, withdrawal from opioids is terrible. It's, a very, very profound and terrible experience, but precipitated withdrawal is much, much worse. It is very intense, and it's very rapid withdrawals that can happen within 20 minutes of taking buprenorphine. And it's never something that we would want to put these fragile patients through. So for a regular induction of buprenorphine, the patient must be abstinent from any full opioid agonist for about 12 to 16 hours. And so this is what it's usually a 2-day process. And day 1 looks like this. We have a patient who has not been on any opioids, who has a COWS score greater than 12. And we give them 4 milligrams of Suboxone. We wait 2 hours. We see if they continue to have withdrawal symptoms. If no, if they do not have any withdrawal symptoms, we can go on to day 2. If they continue to have withdrawal symptoms, we just keep repeating the process until they reach 12 milligrams. So on day 2, then we give the dose that took away their withdrawal symptoms the day before. We also ask them, did they have any additional withdrawals when they went home? And then we keep adjusting. Every 2 hours, we give an additional dose of Suboxone. And so the big question for us as anesthesiologists is, how do we treat patients undergoing surgery or those who are in acute pain, coming in with a fracture, something like that? And so the considerations for choosing a strategy will depend on the anticipated pain severity of the procedure, risk for relapse, and is the surgery emergent or planned? The classic approach for buprenorphine management that even when I was in fellowship, this is kind of how we practiced, is we would discontinue buprenorphine 3 to 5 days prior to surgery and supplement the patient with full opioid agonists, oxycodone, usually, to prevent withdrawal. Okay, and then the plan was to always restart the buprenorphine after recovering from surgery. Okay, and this approach is based on pain patients. Actually, it's based on patients who are taking buprenorphine for pain, and it's reasonable for that patient population. You have somebody who's on a Butrans patch or Belbuca, it would make sense to do this. However, as we've found out, it may not be the best strategy for patients who are taking buprenorphine for opioid use disorder specifically. And so here are the problems with discontinuation. There's an increased risk of relapse while the patient is not on buprenorphine, okay? There's a risk of postoperative respiratory depression or accidental overdose. The mechanism for this is that the patient experiences this opioid deficit when buprenorphine is eventually eliminated from the system. However, we are typically giving these patients full opioid agonists in the meantime, right? We're treating their pain maybe with a oxycodone or hydromorphone. And this is a recipe for disaster. We have buprenorphine, which we consider like a safety net to prevent respiratory depression, is leaving the system. And these hydromorphone that we're continuously giving is ready and available to bind those free opioid receptors. So we need to be very careful and monitor these patients post-operatively. It's also very complex management and a logistical nightmare. So to avoid, the sudden drop-off of buprenorphine from the receptors, you should really taper the dose prior to surgery. That's a long process. That will take weeks. And then reinduction after surgery, like I said, with the induction process, the patient needs to be abstinent from opioids. How many patients in the postoperative period are not experiencing pain and need, oxycodone or hydrocodone? So there's a very slim window for when we can actually restart these patients. And they need to be restarted ideally before they're discharged from the hospital for their own safety. And this really increases our length of stay. Surgeons really don't like that, to have to wait until they are weaned completely off their opioids, then to induce Suboxone prior to discharging. And so I wanted to see how we fared in my institution regarding this challenging patient population. And so in 2019, we did a retrospective chart review and included patients who had buprenorphine and methadone listed as their home medication and who underwent surgeries in our ORs. We excluded patients who were pain patients, primarily, like the ones that are prescribed Butrans patch and the ones who had visits to our palliative care clinic. And so we wanted to see, how are we identifying these patients on MAT or MOUD? How are we verifying the dose? And what is the timing for when we're restarting these medications? And I wanted to see what surgical services had the most of these patients. And so for buprenorphine specifically, it was very variable, but about 60% of patients were restarted in the buprenorphine at some point post-operatively. That meant 40% of patients were not. Methadone, on the other hand, about almost 90% of patients were restarted on methadone post-operatively. So it looks like we're much more confident and comfortable managing patients on methadone than we are for patients who are on buprenorphine. And so some of the study limitations and also barriers that we ran up against was that these medications are underreported. The patients do not inform the clinicians that they are on these medications. And we are working on our medication reconciliation process to try and capture more of these patients, but it's because of the stigma associated with being treated for opioid use disorder. These patients think that the clinicians are going to treat them differently. They're going to think they are bad people. And so they do not even want to tell us that they're being treated for this condition. Another thing that we figured out is that anytime a patient had a prescription for these medications, but it was outside of our hospital system, it was very difficult for us to capture. And so getting back to the stigma portion, so as anesthesiologists, when we do our preoperative evaluation, sometimes we're the first people who may even hone in on this issue, who may ask the patient, if you have issues with this. So I would urge everyone to consider, when they do screen for substance use issues, to screen it like an allergy. Do you have any medication allergies? Do you have problems with substance use disorder or addiction? Destigmatize it. Let's not put it in the social history. Let's put it as a medication problem. And this is actually a suggestion from our local fire chief. fire department chief. This is how the first responders, they screen victims like in the field. And so recommendations are changing about how we should be managing these patients post-operatively. And I'm going to go through a few of the recent reviews and publications. And so the first thing that got my attention was back in 2019, the Pain Medicine Journal published an editorial and stating that patients on buprenorphine for opioid use disorder should continue it through the perioperative period. And so then the British Journal of Anesthesia, they published a special article regarding practice advisory for perioperative management of buprenorphine. And so this is one of the schematics from that article, and basically stating that we need to continue buprenorphine throughout the perioperative period. Continue it preoperatively, no weaning down, okay? And in the hospital, continue it postoperatively, continue, really focus on non-opioid adjuncts like NSAIDs, anti-inflammatories, gabapentin, Precedex, dexmedetomidine, and lidocaine. Only if analgesia, we need further analgesia to consider other full mu agonists. And then discharge, the patient should be on some dose of buprenorphine at discharge from the hospital, okay? And also to really limit the amount of full mu agonists like oxycodone or hydromorphine that we discharge the patient on. And so wanted to quickly review the cornerstones for what an anesthesiologist can do to help these patients. For preoperatively, we can give them acetaminophen, celecoxib, pregabalin, or gabapentin. Intraoperative opioid sparing is very helpful. Consider infusions like ketamine, lidocaine, and dexmedetomidine. Regional techniques are very helpful and should be encouraged in this patient population. So if you can do nerve blocks or some form of neuraxial anesthesia. And then postoperatively, to really follow a protocol-based management strategy, like, continuing the buprenorphine, continuing the non-opioid medications. And so then the American Society of Addiction Medicine published an update in 2020. And even then, these are non-anesthesia, non-surgical clinicians have recommended that discontinuation of methadone or buprenorphine before surgery is not required. And finally, the American Society of Regional Anesthesia just this summer published a special article with recommendations from a multi-society expert panel. And they have also suggested that we do not discontinue buprenorphine. We continue it at the home dose. Postoperatively, we continue multimodal analgesia. We can consider dividing the doses of buprenorphine instead of giving the one dose in the beginning of the day, to split it up 3 times or 4 times a day. And then to discharge the patient back to their to what they were taking preoperatively. They also actually go on to say that there's pretty moderate level of evidence that patients who are not even taking buprenorphine, but who have a history of opioid use disorder, that we should consider starting buprenorphine preoperatively and setting them up with postoperative follow-up for the opioid use disorder. Okay. The one challenging aspect or patient population is this emergency urgent surgery, like the initial patient that I discussed. This liver transplant is considered an emergent urgent surgery. And so what do we do in those cases? So say a patient comes in after a motor vehicle accident, has a femur fracture needs to be taken to the operating room, and then we find out that they have a history of opioid use disorder and that they are taking buprenorphine. We are lucky then to actually know this information. What if the patient was, in a coma, something like that, and we couldn't even know this? So the first question that needs to be asked is the patient currently receiving opioids for pain? So if this is, the patient with a femur fracture, they're likely to be receiving opioids. So if the answer to this question is yes, the next thing we need to determine is when was their last dose of buprenorphine? Was it less than 24 hours ago or more than 24 hours ago? If it was less than 24 hours ago, like the chart on the right, hooray, this is good news for us. We can continue the buprenorphine at their normal doses, and management is simplified, and then we can revert back to multimodal analgesics and going forward there. However, if the last dose of buprenorphine was greater than 24 hours, that's when it is problematic. Okay, so I want to remind you again that if there's a patient who is on opioids, who's not clinically in withdrawal, giving them buprenorphine is dangerous almost. It gives them the precipitated withdrawal. That is a dreaded consequence that we want to avoid. So if they have missed the buprenorphine dose greater than 24 hours, we cannot restart buprenorphine immediately. And the patient needs to be closely monitored with pulse oximetry postoperatively so that we can try to avoid any profound respiratory depression. And then we recommend trying to restart the buprenorphine prior to discharge. In my institution, we have a MAT team, a medication assisted treatment team, who will do this for us. So that would be our recommendation. There is also, back to this restarting, we are working on new protocols. There's some literature out there about using those microdosing for reinduction of buprenorphine while the patient is still on opioids. I was talking about Belbuca, which is a microgram dosing of buprenorphine at the beginning of the presentation. They use very small doses while the patient is still on, let's say, oxycodone, oral oxycodone, to try and to slowly reintroduce buprenorphine to try and avoid the precipitated withdrawal. This is still an evolving area of research to try and figure out which is the best method. And just want to go over briefly the strategies of how we can really optimize multimodal analgesia in these patients. Preoperatively, let's give them acetaminophen. Let's give them gabapentin, maybe 300 milligrams. Be careful in patients who are over a certain age or their creatinine clearance is low. And if there are no contraindications, anti-inflammatories like celecoxib will be very helpful. This goes without saying. We definitely recommend regional anesthetic techniques when indicated. Please make sure you counsel the patients and really convince them that regional is a good idea for them. Intraoperatively, we want to continue multimodal analgesia and limit our reliance on opioids, because remember, these patients, the buprenorphine is blocking those opioid receptors anyway. We would need to give a large dose of opioids, and intraoperatively, large doses of opioids are not always necessary, right? So we could give ketamine infusions, consider giving esmolol to have hemodynamic control if necessary. And consider avoiding remifentanil. I know in certain cases it's unavoidable, like craniotomy. However, there's recommendations that maybe sufentanil would be a better choice in these patients. It's another ultra short-acting opioid, but it also has a very favorable mu receptor affinity. But perhaps it may have less incidence of hyperalgesia or rebound pain after the infusion has stopped. Post-operatively in PACU and even up on the floors in their unit, you're going to anticipate these patients are going to have high levels of pain. It is going to happen. And so we would recommend administering short-acting opioids that have a very high affinity to the mu receptor so that it could try and compete with the buprenorphine, because we're going to continue to give buprenorphine in these patients. And so we want to just compete with that at the receptor. And so fentanyl and hydromorphone are what we recommend, especially in PACU. Fentanyl in the recovery room could be a reasonable option. We recommend avoiding morphine due to its poor mu receptor affinity. So some key points is we want to continue buprenorphine perioperatively. That goes without saying. Discontinuation of buprenorphine can lead to significant morbidity, including withdrawal, increased risk of relapse, or the opposite, and respiratory depression over opioid overdose. We want to utilize multimodal analgesics and opioid-sparing techniques as much as possible. And this redosing of buprenorphine within 24 hours is very critical. It makes management a lot easier if you're able to catch these patients and redose them within 24 hours. And so a couple of take-home messages. I want to urge everyone to consider, this says opioid use disorder, but any substance use disorders like a chronic illness, I would urge everyone to think of it like diabetes or hypertension. And we need to continue the medications for these conditions in our patients. We wouldn't stop insulin in a diabetic. We wouldn't stop medications for hypertension. So let's continue the medications for opioid use disorder. The perioperative period is a very, very critical time for these patients with opioid use disorder. It could be a turning point in their life. And that was seen in my hypothetical clinical scenario for the patient with end-stage liver disease and the transplant. And I would argue that preventing opioid-related morbidity in these patients is equally important as the surgical intervention itself. So please keep that in mind. And so I want to say thank you again. And these are the two things on my mind all the time: COVID and opium. Anyway, any questions, please let me know.
Thank you a lot, Dr. Sharanya, for the great and very comprehensive and very interesting lecture. I enjoyed myself. And I think there is no questions till now. So Professor Dr. Corino Biaciavoli and the Assistant Professor Dr. Sharanya Nama, thank you for both of you again for your time and your efforts and for sharing your experience and enlightening us with all the updates.